right, welcome everyone. We have a wonderful panel of women advocates, so I definitely want to make sure we have time to hear from them, but I also want to invite any other advocacy representatives in the room to also share their examples as we go along this conversation. So, as you know, advocacy organizations, patient communities are involved in all aspects of patient navigation. So we're going to cover a wide range of topics, from clinical research to community involvement to working with for-profit and government entities. So before we get started, I want everyone to have the chance to introduce themselves. If you could give your name, title, patient organization, the focus of your organization, and one thing you're looking forward to. Whether it's the summer, which I'm looking forward to with school being over.
Thank you so much for inviting me today. So my name is Deborah Recasens. I am I am the president and founder of the Hispanic Society of Rare Diseases, but my other hat, I am the director of the Jumpstart program at the Orphan Disease Center at the University of Pennsylvania. In both roles, I work with foundations and organizations of rare diseases, and I help them move the research forward in any way we can. So we work with over 50 organizations that are partners of the Jumpstart program, and I work with them in both roles. And I am looking forward to, and I was talking to somebody earlier about this, just meeting with like-minded people.
Hi, I'm Dion Stalling. I'm the founder and executive director for Rare and Black. We turned 5 years old March 12th. We started right at the beginning of the pandemic. Our mission is to make sure that Black voices are seen, valued, and heard. We do advocacy support, a lot of policy work. I personally sit as the leader of an organization, sit on quite a few advisory boards to make sure that front-facing materials are culturally competent, inclusive. I also do a lot of work in research. I just got the final draft for a paper that I co-authored around patient engagement in rare cancers. And we also do a lot of education in the Black community about what are illnesses, even though we may think it's been going around for generations, letting people know that that is an illness and that you need to be seen.
Good morning, everybody. My name is Mary McGowan. I'm the president and CEO for the Foundation for Sarcoidosis Research. For those who may not know what sarcoidosis is, 200,000 people, it's estimated, in America are living with the disease, and 1.3 million worldwide. So it's at the very high end of rare disease. It is an inflammatory disease that can impact any organ in your body, and most patients who have it have multi-organ involvement, but 90% of the people have lung involvement. So our mission is hopefully eventually to find a cure, but along the way to do education, awareness, support patients. We elevate research, and we do a lot of advocacy work. Our headquarters are in Chicago. We have a Washington, D.C. office here due to all the advocacy work that we're doing. I'm really looking forward to October, and the reason being is we are celebrating our 25th year anniversary. The organization was started by a patient, and now it's grown to be the leading international organization. But we're doing a big awards gala in Chicago, and we're celebrating the 25th year anniversary. And yes, it's about reflecting back, but mostly it's about reflecting forward, and very much looking forward to the future of this building of momentum about sarcoidosis in the world. Thank you.
Good morning. My name is Nicole Rochester. I am a pediatrician by training, a healthcare consultant, and I've had the honor since December of 2021 of being the medical advisor for health equity for the Immune Deficiency Foundation. And I'm looking forward to engaging with many of you, networking. I'm looking forward to more meetings like this. For many of us in this space, of course, the last few months have been challenging, but I am very excited about the fact that the work continues, whether we have to rename it, whether we have to reclassify it, the work continues. So I'm really excited about the future of this work that we do.
Thanks, Nicole. Good morning, everyone. Paula Eichenbrenner, Executive Director for the Myositis Association. Myositis is a rare, autoimmune, incurable chronic condition. There are several forms of myositis, and at TMA, we help families affected by all of those forms. So we are an umbrella organization for about 75,000 families here in the US. And I'm very much looking forward to the month of May, although it's incomprehensible that it's almost here, but May is Myositis Awareness Month, and as a proof point that the world is not completely burning down, I will offer that we were able to, for the first time, work with the US House of Representatives on a ceremonial resolution for our observance month, and our community is really excited about that, and I hope it turns into something more substantive, but it's been an affirmation to us. So things can always get better, even if slightly.
And I'm sorry, I forgot to say the focus of the organization. So the Immune Deficiency Foundation exists to improve the diagnosis, treatment, and quality of life for individuals impacted by primary immunodeficiency.
I'm looking forward to Saturday. Me and my best friend are going to Ocean City for the weekend. Sorry, it's not business, but that's what I'm looking forward to.
Sounds good to me. All right, so we're going to start with clinical trial participation. We just heard from a great set of panelists, and Marshall Summers mentioned 60% of rare disease trials fail because of recruitment and retention. So my question to you are, what are the top 2 challenges you see in your community that hinders participation in clinical trials and or understanding of their condition? So Debbie, I'm going to start with you, and then Dr. Rochester, and then open it up to the rest of the panel.
Well, I think in the communities that I work with, very ultra rare diseases, most of the cases, and the Hispanic community, is diagnosis, right? So it's the lack of diagnosis. We don't have enough patients that have been identified. So we work a lot with their communities to find ways to identify these patients. It becomes very challenging, especially in the Hispanic community. We have extra challenges, particularly right now with immigration and legal status of many of our families. So we find very difficult to get our families to be diagnosed.
Well, similar to what Deborah just shared, one of the primary barriers for clinical trial participation among patients with primary immunodeficiency is also diagnosis, delayed diagnosis. The journey to diagnosis for the average patient with PI is 9 to 15 years from the onset of symptoms. And so that delayed diagnostic journey significantly impacts clinical trial participation, even awareness that they have the disease in the first place. And also, I would say mistrust, medical mistrust, and misunderstanding of the purpose of clinical trials and how to participate in clinical trials, particularly among minoritized and marginalized communities. There are historical and present day examples of bias and discrimination and medical abuse. And so it can be really difficult to reach those communities and to really encourage their participation in clinical trials.
So I know that all of your organizations have some great examples of overcoming barriers of clinical trials. So if you could describe 1 or 2 programs your organization has implemented to address those barriers. And Dion, I'll start with you, and then Mary.
What we've done is usually we get emails from organizations that are doing something around Black people or an illness that significantly affects us as a group. And what we've done is act as a go-between or a liaison. But like I told Dr. Cole this a while ago, there are about 43 million Black people in this country, and there are 43 million ways to be Black. So there's no, seriously, there's no nothing set in stone, but you need to be able to, again, the organization needs to be able to be trusted, and you need to make sure that you follow up. And so I can name 2 organizations that we're involved in now that are doing research studies around certain diseases that they need to show up in a community before they need something from the community. And also, once you've gotten maybe tissue samples or information about this person's family or blood work, make sure you keep up with them, because trials and studies can be very long. You may have a 5-year study and the first year is just to recruit, and they may not hear from you anymore. Now they're thinking, oh my God, they're selling my stuff to someone. Or like, keep people engaged, whether it be a Facebook group. I know medical communities don't like social media as far as privacy concerns, but even if you have a newsletter to keep people involved. Okay, we've recruited 20 people thus far, but the goal is 75. Let them know what's going on so that the trust is not broken.
Great. So I'm going to share a little bit about a national campaign we just did. It's called Ignore No More, which actually resulted in something that I believe is really going to change the whole dynamics for clinical trials in this country. And I'll tell you what that is, but I'm going to tell you the story and how we got there. So unfortunately, African American women by far have the worst outcomes and highest prevalence for sarcoidosis. They're 3 times more likely to get sarcoidosis. They have 18 times higher hospitalization rates and 12 times more likely to die of the disease, and they die at a much younger age. So really wanted to do something about this. So created this national campaign, Ignore No More. The first phase of it was completely focused on the Black female community and clinicians. We had an infographic, webinars, we had a clinician podcast, we had social media, we had a lot of elements into this campaign. We had 26 partners on the campaign, including medical societies like the Association of Black Cardiologists. We had churches like Balm and Gilead. We had government partners like the Heart Truth Campaign. All reached 500,000 people in a very brief 5-month campaign that we worked on this Ignore No More campaign. We launched phase 2 of the campaign just last year. This was focused on clinical trials in the Black community. We had an IRB-approved survey. We sent out a press release to the entire nation inviting the Black community who are living with sarcoidosis to complete the 52-question questionnaire. Our goal was to have 200 responses. We had 406. We had a lot of robust data. We immediately put together a key opinion leader thought workshop, experts in the nation. And they took a deep dive into the data and came up with recommendations. We then put together patient focus groups to look at the recommendations and for the patients to come up with their own recommendations. With all that data, we wrote a 62-page white paper. It's on our website if anybody wants to look at it, full of information. We then had a congressional briefing and we launched the white paper. And at the briefing, we stated that we wanted to change FMLA and we wanted to provide a $5,000 tax credit for anybody in the nation who enrolls in clinical trials. The reason why we did that is because the 4 top barriers, and this is an order that the Black community identified as barriers to clinical trials, was 1, never being asked. They're not being asked to enroll in clinical trials. Number 2, they don't have enough information about clinical trials. Number 3 was financial and fear, here it is, fear of job loss. And number 4 was trust. That's in order. So that's why when we were at the congressional briefing, we thought we're going after the FMLA. We're gonna, and that's what we did. After the briefing, making those statements, we hired lawyers, brilliant lawyer who really helped us on this. So basically, the lawyers said, don't write to the Department of Labor asking them to change it. Write to the DOL and ask them to clarify whether or not clinical trials are covered. That was brilliant, because it's much harder to change FMLA, right? So anyway, we did that, and we included family members to accompany somebody in clinical trials. We waited for a year. We never got a response. So we put together a coalition of 26 members. We did 40 congressional visits on Capitol Hill. And within 2 weeks of doing those Hill visits, we got a 6-page response letter from the Department of Labor saying now in this country that if anybody takes time off from work, their job is protected and so is a family member who accompanies those individuals. This just happened. It's not really even public yet. So we're working with the Society for Human Resources Management. We're putting this out to all human resources directors across America. We've been talking to a lot of law firms about this issue. And again, it came from the rare disease, but I feel very confident that this is going to really move forward medical research in America for all chronic diseases.
Mary, when did that just happen? You mentioned.
So the letter that we got back from the DOL was late November. We put out a press release, I believe, in January, and we have a couple of media interviews coming up on it. But really, the main focus was getting with the human resources directors, because it was interesting to us. As soon as we put the press release out, legal firms were writing blogs and communicating about this, right? Because the potential lawsuits, right? And we've heard from many of the doctors in our community that they have already filled out the form for FMLA leave for people who are in their clinical trials, so that these individuals can stay in clinical trials. So again, I mean, this is going to have really major impact, I think, on America for all chronic diseases.
Awesome. Thank you. And Debbie and Dr. Rochester, an example or not of how your organization.
You know what, Pam? Let me step in here, because at this point I would also like to say that Mary used to have my job, and so I am familiar with the uncomfortable pressure of having to follow Mary McGowan's excellent example of leadership. So there's really no way to level up to that. But I do want to share something that might be helpful if others in the audience are representing patient populations with diseases that are not genetic, in fact, because that is the work we do at TMA. And TMA was founded in 1993, so based on 30 plus years of attempting to demystify myositis, I will say the science has come a long way, and I think the patients are very motivated, very expert. It's still not very well understood. What is the disease? What is it caused? The best science, and here I'll look to you, Dr. Rochester, the best scientists think that there may be a genetic predisposition, but often an environmental exposure that causes a trigger. And so I think that's really important in our work, and what we are trying to do to overcome these barriers, increase understanding, and ultimately increase trial enrollment is to talk more about the potential environmental exposures that may cause myositis and what links there may be to the social drivers of health that are experienced by underrepresented populations with this disease. So we're at the very beginning of figuring that out. We have some new resources for our community and some great partners who are helping us do that. But maybe in a year, I'll have something that comes up to that. And in the meantime, Debbie, you can go ahead.
So those are, yeah, again, hard to follow. We do something on a little bit smaller scale. We work, our foundations that work with us have an issue of, actually the miseducation comes from the PCPs, the pediatricians that they see. They live, with smaller areas, rural areas, that they've never seen these patients. I mean, again, we're talking 100, 200 patients in the country that these doctors have never seen. So one of the programs that we have at the Jumpstart is that we match genetic counselors with the foundations, and a lot of them are working on one-pager informational material to the doctors. So in that way, we make sure that they are able to, because these foundations know more than anybody. Patients are now the knowledge holders, and so we're working on putting these documents in a way that the doctors can identify if they come a patient that comes with certain symptoms. They can perhaps think, oh, maybe this is one of these diseases that I've been told about. So we're trying to increase a little bit the diagnosis by going directly to these physicians that first see a patient before they get to go to see a neurologist, or actually going to a bigger university or a hospital where they might see an expert on the disease.
And I'll just share, there's two programs that I'm really excited about with the Immune Deficiency Foundation, specifically around increasing awareness and overcoming some of these barriers that we've all been talking about to clinical trial participation. One is a strategic partner roundtable. One of the things that we realized, and I think all of us saw this in COVID, is this idea of, one, going to the community, not expecting people to come to us, and also the idea of trusted messengers, and really realizing that, as a quote unquote outsider, to go into communities with information is not always the best way, and how can we best leverage the individuals that are already serving these underserved communities. And so with the Strategic Partner Roundtable, IDF has partnered with organizations like the Rare Disease Diversity Coalition and National Medical Association, National Pharmaceutical Association, Hispanic Thank you. Hispanic Society for Rare Diseases, Rare and Black, and many others. And the idea is really to have shared priorities and goals. How can we collaborate? How can we leverage our unique perspectives in our communities? How do we find common goals? And then how do we present at each other's conferences? And really, it's been a wonderful partnership over the last, I think this is second year now. So that's one significant advancement at IDF. And then the other, specifically to address awareness as well as medical mistrust, is we have a podcast series called Bold Conversations. I'm honored to be the host of that podcast series. And we've done a number of episodes on everything from what is PI to talking about health equity and implicit bias. We've brought on patients as well as lots of other experts. We've talked about the business case for health equity. And so that's really another attempt to reach an audience outside of the traditional medical community. It's called Bold Conversations.
Thank you for reminding me, shameless plug. We also have a podcast, all in Spanish, called Más que Raras, More Than Rare. And we interview clinicians and researchers and leaders in the rare disease community, 100% in Spanish. And it's been reaching beyond our country. We have a lot of people commenting from South America and from Spain. So it's a way as well for people who usually feel like an outsider because of the language that they speak, are able to get more information in their own language.
Thank you. That's a great segue to the next topic, which is around community and volunteer engagement. So I'm going to open it up to the panel. Paula, I'll start with you, and then we can go down the line. But what does successful community engagement look like for your organization?
Thanks, Pam. At TMA, we're particularly proud of our affinity group network, which currently numbers 9, including groups in Adelante, Spanish speaking. I have a couple great doctors for that podcast, as well as a men of color and a women of color group. And the women of color, probably not surprising to those in this room, they were the trailblazers. They were the first affinity group to be established 5 years ago. And so I want to share a few things that they have done in that time that have really galvanized that segment of the TMA population. They have so many innovative ways. I could go on for a whole hour, so I had to force myself to pick 5. One thing that they're doing over the last year is a BEST program, where there's an acronym for Big Sister in there, and they have every month they swap out mentors and mentees. So it's very innovative. In our space, we have some other kind of peer-to-peer mentoring or counseling, but it tends to be a longer-term relationship. Like you work with a mentee for a month, and this is a little bit of mentoring to be sure, but also just more focused networking. And as the group has expanded now, it's several hundred women. It's proving to be a very effective way for them to stay highly engaged. So they're doing that. They have also a number of subgroups, a compassion committee that helps with members who are in health crisis or having myositis flares. They celebrated their 5th anniversary last year, as I said, and they had awards to reflect their mission, which is around education, empowerment, and encouragement. They've done recent programs in the last year on social connections and resilience in rare patients, as well as the mortality rate for Black women in myositis. We have built out a YouTube playlist on the TMA channel to host the archive versions of those programs, which has been really helpful. And last year, we opened up a Myositis Africa support group that's in partnership with the Women of Color. And so they are meeting every other month on Zoom, and we have about 120 women who live in Africa who are actively participating in that group. So I think it's really an excellent example of community engagement, and I'm happy to tell you all about the wonderful things that they have done, to be clear. And on our website, you can learn more about their excellent efforts.
So I would say successful community engagement at the Immune Deficiency Foundation really looks like allowing the community to lead these types of discussions and to really provide what is necessary based on what the community says. And so we have a very large volunteer network, over 400 individuals that do a number of things. They participate in health fairs throughout the country. They have a plasma ambassador program, so they have individuals that actually go to the plasma donation centers to thank those who are providing this necessary life-saving treatment for individuals with primary immunodeficiency. And then there are patient advisory boards that are very much involved in the activities at IDF. There's a community advisory board, there's a youth advisory committee, so they're also very intentional about engaging the pediatric population, the youth and the teenagers as well. And then I mentioned the strategic partner roundtable. I'll just mention that again because that's another way that we are engaging with communities that historically have been kind of left out of the conversation. We know that with primary immunodeficiency, if you look at the disease registry, it is largely white. And so I can say as a pediatrician, we were kind of taught in medical training, not that long ago, that these conditions look like a certain type of ethnicity or race. But what we know from some more recent studies is that there are at least like 20-25% of individuals with PI are in communities of color. And so making sure, again, that we are partnering with healthcare professionals, with community-based organizations that are serving those individuals is important. And then one final thing I'll say that's really innovative is that the IDF produced a film, a feature-length documentary film called Compromised, and it was debuted at the annual conference last summer, but over 1,000 individuals have registered to screen this film, including medical professionals. It's being shown to medical trainees and in communities. And so that film features 6 individuals, one of whom is Miss Dion here, patients with PI, and it really explores in a very beautiful way their journey with primary immunodeficiency. And so that's a very unique and innovative way to spread awareness in the form of a film that is very intriguing and heartwarming as well.
Great. So we have a lot of community engagement. I'll talk about one of our most recent, very successful programs. Actually, it's transforming the way that we work at Foundation for Sarcoidosis Research. So we launched what is called the Global Sarcoidosis Clinic Alliance. Basically, this is a membership program where hospitals and institutions across the globe actually now join our organization. In joining, they pay us $5,000 membership fee. So as a side note, it's an extraordinary model for all of us in the nonprofit space. How do you get compounding, unrestricted revenue coming into the organization? That's one great successful thing. But there's 4 pillars of this program. I'll be really brief. One is clinicians, one is patients, one is research, and one is business outcomes. So the whole clinician side, again, transformed what we do. We set up leadership committees. We are talking to these doctors daily. It is just amazing. They're creating clinician programs for clinicians through our organization. They're all CME. They are now putting together, are putting together a national registry for sarcoidosis, which is going to be transforming this disease. So, but let me go to the patient side, because that's really more what the question was about. So from the patient side, when each one of these hospitals join our organization, we work with the hospital to get 4 patient volunteers to step up to the plate. When they step up to the plate, we train them, extensive training. 2 of them become community educators, and 2 of them establish and run peer-led monthly support groups at those institutions. The community educators are out in the community, they're telling their story, they're working with the media, they're raising money, et cetera, and the other ones are doing the support thing. So we just flew all of them together to the Cleveland Clinic for an entire weekend. We paid for it, all expenses, because thanking them for the work that they did, and gave them advanced training. And they got a a tour of the Cleveland Clinic of the Sarcoidosis Institution there. So anyway, I'll stop there. I go on a long time with that program. But point being, and I always say this at FSR and the work I've done previously, you know, we're small, rare disease organizations. And here's the question I always ask myself: how do I align myself with entities that are way bigger than we are? Because we're a team of now 15. When I joined, there were 5. How do we align ourselves with entities that are bigger than we? Because we can't do this with small teams and small budgets. So I'll leave it with that.
She would segue into small budgets, right? So what I'll say is, actually, I had a call with someone that agreed to be a volunteer. I'm like, I cannot pay you, but I need to take some of this off of me because I do a lot, and I'm also a patient. So she is going to be the director of community engagement, and actually she's a family, she's the mother of someone that I helped get help with in Missouri with DFS. This is something that Black communities go through when their children are not diagnosed. She almost lost her child to the state because of neurological disease. And she was actually the very first, I don't even know how she found me in 2021, but she was one of the first people to work with AT&T for them to give me joint, you know how you sign up for, I can't remember the exact name, but you sign up with your employer and they match the donations. And so she was the first person to do that. And what I want to say about community engagement, we have a program called the Restful Revolution, where we go to HBCUs to teach them about sleep hygiene, because narcolepsy presents itself different in infants, children, and a lot of people get diagnosed when they go off to college or they become adults, because it doesn't look, you're not just falling asleep. You're staying up all night and maybe napping through the day with children going to school. We also have a program called Take Space, where I did a presentation, smaller presentation, to see how young people, because they are different, like things, and the goal is to help them transition out of pediatric medicine into adult medicine. It's 18 to 30. We teach them, give them different resources so they'll be able to be adults that know how to speak up for themselves, be well-versed in their conditions, and how that looks like and what their options are as an adult versus the cloak of closeness in pediatric medicine, where everything is cohesive, where you're just thrown out in the woods when you're over 18. And the last thing I'll say, we also are having a caregiving conference in November, which will be around mental health, because it's hard to be a parent or a family member of a rare disease patient. And the last thing is we had an inaugural Rare and Black Patient and Scientific Engagement Summit, and I'm happy to say that people got diagnosed with Ehlers-Danlos syndrome, quite a few, because they didn't know what it was, and that was the design, to have clinicians and researchers in the same space as patients. And so I'll leave it with that, but those are the things that we're working on.
Awesome, thank you.
For us, success looks, I think, like everybody else mentioned today, it's where the patient is in the center of whatever we do. And I'm gonna move it to research, which is what I do mainly, and we make sure that all of the programs that we work at the Jumpstart, the foundation and the organization is in the center of it. So we work with these organizations. Actually, we go from little funding to no funding at all. But so the families, as you all know, they work really hard. They are the ones raising the money. They are the ones putting together the funds to fund research. So we help them put together grant programs. We help them find the people that are going to be doing the research. We organize NIH-style grant programs for them with reviewers and the whole system. But we make sure that the foundation is at the center of these programs. So we work with them to identify the different whatever we're going to be funding, they are part of that. They are part of the process of review, and after we have experts review it, they also look at it and talk to the community and make sure that their SAVs and their patients agree to what is going to be funded. So even at the research, basic research level, we make sure that the foundations and the patients and the parents are part of it.
Great, thank you. All right, so next we're gonna transition over to working with the government and or for-profit organizations. So the question is, what are some of the unique ways your organization has worked with government bodies and or for-profit organizations to drive awareness and access to care for your communities? So I want to start with you, Mary, since you gave that great example of FMLA.
Sure. Thank you. So adding on to the FMLA, we just launched 2 months ago a segment of this. And basically, we have started something called Champions for Change. And we are asking every company, organization, entity in America to do one thing. And that is to provide one free day, paid day off for an individual to enroll in clinical trials. Just one day. And if you join, you get part of this Champions for Change benefits. I won't go into all of that. But the focus here is, part of it is to pay the employees, which we know financial, I mentioned it was number 2 on the thing, right? You're gonna pay them, because FMLA doesn't pay them, their job is just protected. This is about money, but really what this is about, it's about having the conversation in corporate America about clinical trials. We all go to a lot of conferences and talk about these things, but where is corporate America in supporting the work that we're doing, right? And people are their biggest assets. If you don't have a healthy workforce, you don't have a healthy country, you don't have a healthy company. So anyway, that's one. And then the second thing is, again, looking at corporate America. We're working a lot with retailers. Right now, we have a really robust campaign going on with Walgreens. During Sarcoidosis Awareness Month, every store in Alabama of Walgreens gave out educational flyers about sarcoidosis, and they did a point of sale. It led to over 90,000 distributions of educational flyers. Again, you get back to, how do we align ourselves with entities that are because there's no way we could do that at FSR. Right? For those of you who know, when I was CEO of Women Heart, we had an unbelievable campaign with Burlington Coat Factory. $9 million point of sale. Year after year, we would go into the stores and we would do blood pressure screenings. Literally, people going by ambulance to the hospitals with stroke level hypertension. How do we align ourselves with these entities that can help us, but for some reason we don't seem to be active in that space? So that's our mission at FSR. Helpful?
Yes, thank you. Dr. Rochester.
So IDF has a long history of partnering with government officials. There's a public policy department with several staff dedicated to those efforts. Specifically around vaccine advocacy, specifically in the climate that we're in. I think one of the things that I'm most proud about at IDF is that there's a lot of proactive engagement with government officials. There are engagement with Senate committees, there are public presentations, there are statements that are issued with regard to the importance of vaccines, specifically in the primary immunodeficiency community. And then there's also an IDF Advocacy Day. In fact, it's tomorrow, right? Tomorrow and April 30th to May 1st. This is an annual event where, again, large convening on the Hill, meeting with representatives. And one of the things that, again, as a mom and a pediatrician, that I wanted to mention is that they have the Young Advocates Academy. So not only are the adults in the PI community engaging with senators and Congress people and advocating on Capitol Hill, but there's a whole program to teach the youth and the young adults how to advocate at that level, which is really important in terms of passing on the baton. And then the other thing I would say about that is that there's engagement with health insurance companies. There's a lot of barriers with regard to treatment, access to treatment, payment, policies, and so there's been active engagement between the Immune Deficiency Foundation and health insurance companies to do advocacy with regard to treatment access as well.
Great, thank you. Paula, Dion, and then Debbie.
I'll share quickly about a program we did last year in partnership with argenx, a pharmaceutical company that has a trial in myositis. Actually, they have 2 trials in myositis. Credit where it's due. Great partner, so not a government example, but a for-profit partnership with TMA. We had a patient ambassador award that was presented to Karen Alexander, who lives with dermatomyositis and is a trailblazing supermodel. You may not know her name, but you would know her face. She was the first Black woman on the cover of Elle and very prolific. And so she accepted the patient ambassador award, and we had a PR campaign and a number of impressions through that partnership.
Most of you all are talking about the federal government. We fly in as partners with different organizations, but we also, as an organization, Rare and Black, do work on the state level. Newborn screening is extremely important to us. I work with the Louisiana Rare Disease Advisory Council. They're a baby. I think they got together like maybe a year and a half ago. Missouri, that's where I'm from, and I was really gung-ho about being part of their rare disease advisory council. However, the Constitution wasn't written correctly, and the governor that we had, basically everything had to be appointed, and so he didn't feel that rare diseases were important, so he didn't do anything. So we had to go fight through different districts within our state to be able to get those House of Representatives to convene to show them their rare disease and newborn screening is important. But at the same time, know that Missouri has a lot of children that die as infants. And so they all got together and they voted again to change the Constitution so we could have a Rare Disease Advisory Council. But now we don't have enough people to know about rare diseases, and we don't have anything. We are working with Mississippi, the Delta, to get an advisory council or some type of state entity together, because there are a lot of Black people that live within the Delta that have an extremely high number of rare cancers and rare diseases that some don't have names, and we believe it's environmental, not all genetics. So I'm working with a Dr. Carpton at USC to be able to bring some type of legislation and awareness so we can get funding. We all know that Mississippi is very poor, and health is not always on their agenda. They're trying to live, just live normally. So we're working with poor states, and then I'm working with a woman in St. Croix around sickle cell awareness. That event was supposed to go on in September, but we changed it due to funding limits. So it may be later in the year or the beginning of 2026.
Can I just add one thing? I forgot to mention the federal work that we did. So 2 things, and if anybody hasn't done this and you're interested, I'd be happy to work with you on it. But one was a patient listening session with the FDA. And the other one we just did was a patient-focused drug development session with the FDA, with over 350 people in attendance. And I can say this, since then, we see FDA all the time in our programmatic activities. You know, we're watching who's attending your virtual educational events, and it's amazing how many FDA representatives are now paying attention to sarcoidosis. So I would assume they would be doing that with other diseases that take the time and effort to do these patient-focused drug development sessions and patient listening sessions. So just wanted to add that as well.
Great, thank you. So we have one final question for everyone. So what is one key action we must take to ensure underserved and underrepresented individuals with rare diseases remain included and actively engaged in their health care? So I'm going to go down the line here.
Sure. So I feel, as particular with the Hispanic community, so yes, the minorities, you know, we are representing different sections, but it's important to recognize that that there are differences as well as we are in the same boat in many cases, but we have a lot of differences, and the Hispanic community has specific challenges that have to be recognized by the rare disease communities, by pharmaceutical companies that are different. So it is. I always like to bring that to the front, saying we have the immigration issues. We only have not only language, but we have legal status, and we have different cultures. Even within the Hispanic community, we are very different one from another. So it's very important for us to recognize that the differences are there, that the challenges are different, and then we have to find ways to counter those challenges as well.
I was going to add, similar to her, I also believe that Black people have, in this particular country, have issues that are not addressed as a whole, and it starts with education of the medical community. I don't necessarily think that even though rare diseases are rare and it looks different, just like I used the example of the woman that got DFS called on her when her daughter was hitting her head against the wall to the point where it was bleeding. Those types of things are important when we go to diagnosis. I can use myself as an example. I was born with primary immune deficiency, and I remember growing up that my mother was a single mom because my dad died when I was very young. And they used to say, well, you're not making her take her medicine. We have to take stigmas off of people because we don't know what it is. Primary immune deficiency, we don't respond, a lot of us don't respond to oral antibiotics. And so when we're talking about advocacy, understanding the community, and I use this example, I know it's a woman here that heard me speak in Boston last week, and I gave this example about trust and how to galvanize people. And I can say this because there are a few men in the room, but you know, when you see this fine woman that you want to meet, and she's like, oh my gosh, she's so beautiful, and she's walking up the escalator, and you run, and then you talk, and you all get to know each other, and you find out what she likes, and you decide to have a date, and you bring all of those things that she told you that she needed and she wanted. You're trying to win her over. As a group, community engagement, academic institutions, pharma, all of us, we need to show up to these communities before we need something from them. Let them know that they can trust us with their information, with their life stories, that you won't sell them out. We have had at Rare and Black people, well, we'll give you money, but we need you to gather data to give. I'm not gonna do that. And if I have to cease doing what I'm doing, then I will. But you need to show up when people, before they need you. If someone is having something, collaboration is key. And I think that all of us want to move rare disease forward, whether it be by cure or even, I just would love a medicine to make me feel painless 5 days a week versus 7. And so I also identifying what is needed in the community, and by asking people, like, especially in drug development, what is the goal that we can't, it costs too much for a cure, but what is it that would make your life better?
Yeah, well said. I agree with all of that. And that was really a great summary. I would add, again, the education component part of it and engagement. Like, how are we doing that strategically? And I think we have a lot of improvement there that can be done. So going back to the Ignore No More campaign just for a second, the fact that the Black community was not being asked to enroll in clinical trials as the #1 thing that they identified. What was really interesting in that data was that only 6% of the Black community who were asked to enroll in clinical trials did not enroll. Only 6%. So what is that telling us, right? It's not that the Black community is not available or that they don't want to, but how are we strategically and really with accuracy, helping them understand what the opportunities are for them, and when they tell you that you take action on it. What are we doing to solve the problems? We can't sit and talk about the problems, right? What are we doing, and feed that community back to the Black community for more re-engagement, more interest, more understanding that, okay, this is gonna help not just the Black community. Again, the Ignore No More, I think, is an example of that. The Black community helped the entire nation. That's the story of that campaign. And we're so blessed with that. So how can we learn more? And we have to learn more.
Ooh, I'm excited to follow that, Mary. That was awesome. I think there's a critically important question that all of us should ask with regard to engaging underserved communities, and that is, who is not at the table? I think that we often, even with our well-meaning intentions, we often end up, preaching to the proverbial choir. And so one of the things that the Immune Deficiency Foundation has done is to really do a concerted effort to gather demographic information about their community. Who's in the community? Are we talking to the same people over and over again? And so finding out, asking who's missing, who's not at the table, making sure that you know who is at the table, and then very intentional efforts to educate, to increase awareness. That includes everything that we've been talking about today, providing culturally resonant information, how I speak to someone in the Black community, acknowledging what Dion said, we're not all monolithic, right? But how I speak to one community is gonna be very different than how we speak to a Hispanic community and how we speak to an LGBTQ plus community. So we really have to make sure that we're literally speaking the language that our communities, that they resonate with, and actively always questioning who is missing, and then taking steps to engage those who are not already at the table.
Thanks, Pam, for the great question and for the really special prize of answering it last. I don't know what to offer beyond what my co-panelists have said so well, but I will track back to the idea of lifting inspiration. And Mary's made a very compelling case for scaling up and for affiliating with larger institutions. And I often wonder in this work with rare advocacy, what could we be learning from our advocates who work with much more widespread and more prevalent diseases? And so you and I have spoken before about potential patient navigation and financial toxicity programs that are very widespread in cancer advocacy, and can those be applied in rare? And should we perhaps be a little bit cautious about staying in our own rare space all the time, and should we be looking for inspiration elsewhere? So I think if we take that mindset plus everything these brilliant ladies said and go forth, we will definitely transform healthcare for our patients.
Thank you. And save the best for last, because I totally believe in patient navigation and bringing that more into the rare community space. Well, thank you so much, ladies, for your time and your energy and your commitment to the rare disease space. And thanks, everyone.